Thank you, everyone. Appreciate everyone's patience and allowing us to take a brief break. We will now reconvene the ACIP meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For the speakers who have joined us today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen that you see there, so you know how much time you have left. We really appreciate the diverse viewpoints that are respectful in nature and focus on the issues being discussed at our meeting today. Thank you again to our speakers, and we look forward to your comments. Our first public speaker is Mr. Paul Hennessy.
Hi. I was supposed to comment at the meeting on the 12th, but I think only one person spoke during public comment, so definitely urge you to look into that issue. I know there were a lot of commenters who didn't get to speak, but yeah, I'm here to talk about future of vaccine rollouts, not just RSV, but COVID as well. I thank the ACIP for approving those 3 vaccine options last week, but once a year shot does not go far enough considering protection wanes after about 5 months and there's multiple waves of COVID per year. So COVID's not the flu, so a shot schedule like the flu just isn't working. Once a year vaccine just isn't enough to protect us from a virus that fuses brain cells, causes blood clots linked to diabetes, dementia, and more. And furthermore, like COVID and RSV are airborne illnesses. So the vaccine-only approach doesn't properly reduce transmission as much as it can. Clean air tech and masking must be encouraged along with vaccines and even required in places like medical settings. Pediatric approval for the Novavax COVID vaccine is also needed as soon as possible. I definitely appreciate that the RNA has been approved, but children like adults deserve the choice. Novavax is shown to wane less quickly than mRNA and offer broad immunity against variants, and successive doses actually enhance protection as well as offer some upper respiratory protection. So children deserve this excellent choice as well. And finally, just going forward, I would definitely like to urge ACIP to approve vaccines before surges. That includes both COVID and RSV. Moderna and Pfizer's COVID vaccines were ready and I believe submitted a number of months ago, but it took until September to get approval. It's so important to approve both COVID and RSV vaccines before the school year so children are protected going into school. Thank you.
Thank you for your comment. Next, we have Jane Hall.
Hi, can you hear me okay?
Yes, we can. Please go ahead. Thank you.
I'm Jane Kaplan Hall, and I'm speaking on behalf of TRAPAD, which is a patient advocacy group whose members are transplant recipients and or are immunocompromised. We strongly urge the committee to recommend the RSV maternal vaccine and to add it to the Vaccines for Children program so as to immunize the child through the mother. Our TRAPAD advocacy group commends the committee for placing the AB nirsevimab, not sure I'm saying that right, on the Vaccine for Children program, taking the groundbreaking step of recommending passive immunization, which ensures that it will be covered, and urges the committee to do likewise if and when a monoclonal antibody or antiviral prophylaxis against COVID is authorized by the FDA. This would be especially crucial to the population of immunocompromised people who do not respond to vaccines and will greatly benefit from effective vaccine or prophylactic treatments that can both save lives and improve quality of lives for those affected. We would also hope that the committee in future deliberations recommend the RSV vaccines, not just for the 60 and over, but give access to the RSV vaccines for those who are immunocompromised or high risk and those living or working with vulnerable populations. Thank you for giving me the opportunity to speak.
Thank you for your comment. Next, we have Dr. Rosalie Bright.
Hi, can you hear me?
Yes, we can. Please go ahead.
Hi, good afternoon. I'm Rosalie Bright. I have a Doctor of Science in Epidemiology and had a 30-year career as a federal medical product epidemiologist. For meaningful consideration of public input, the substantive materials for CDC advisory committee meetings, the slides, white papers, etc., should be available to the public for at least a week before the meetings to allow adequate time for thoughtful, in-depth public review and comment. People who had already signed up for comment should be notified the same day the materials become available. The oral public comment session needs to be expanded to at least an hour and occur before motions and votes. RSV vaccines have been approved by FDA for older adults and infants. A month ago, the one under consideration today was also approved by FDA for pregnant people and infants. I support expanding the use of RSV vaccines and have several points regarding the specific RSV vaccine under consideration and RSV vaccines in general. 1, for non-pregnant adults, the RSV vaccine has been approved for people 60 years old and over. I urge the sponsors to quickly study the usefulness of the vaccine minimum. All people at high risk from RSV and all people in professions and situations that often interact with people who are at high risk of RSV. That is healthcare workers, patients and visitors, and childcare and school staff and children, etc. 2, RSV infections have risen significantly year over year during the COVID-19 pandemic. If the rise is due to immune damage from COVID-19, the potential benefit of offering go. 3, RSV circulation is seasonal, typically starting during the fall and peaking in the winter. The peak RSV hospitalization season has been moving to earlier in the calendar year in the specific surveillance areas of the US. Please offer the RSV vaccine in the summer to prevent the surges that have recently been starting in September. 4, because getting the RSV vaccine is recommended for a narrow window of pregnancy, 32 to 36 weeks of gestation, availability for pregnant people needs to be speedy to help as many pregnant people as possible this fall. 5, RSV vaccine efficacy wanes. That's fine for pregnancy and infancy. However, please consider recommending that pregnant people should be revaccinated during each subsequent pregnancy. In addition, older adults should be offered semi-annual vaccinations. 6, RSV is part of the trio of airborne viruses that CDC is already campaigning about. While the COVID-19, influenza, and RSV vaccines reduce the risk and severity of infection, they don't entirely eliminate infections, and some people should not take them. I ask CDC and the vaccine sponsors to include other precautions against airborne viruses in your public messages, including N95 or higher quality masks, otherwise known as respirators, and air cleaners with HEPA filters and fresh air ventilation, especially those that vulnerable patients must attend as staff or clients, including healthcare facilities, schools, and prisons. Thank you for this opportunity to comment.
Thank you for your comment. And I want to thank all our public comment speakers and those who take the time to submit written public comments via the CDC docket as well. With that, we will move on to our voting section of the meeting. So if my colleagues in the room would please put up the first vote. I'm happy to open it up if there are any additional comments or questions the members would like to ask before we proceed with the voting. And while we're waiting to see if there's any additional comments or questions, I'll ask the voting members to please put on your video. Ms. Stinchfield?
Yes, Patsy Stinchfield from NAPNAP. Just as we're getting everyone on camera here, I did want to add my comments about in the 20 years I've been participating with ACIP. This has got to be one of the more complex decisions that's been before this committee. I especially wanted to, as a member of the RSV work group, acknowledge Jefferson and Catherine for the phenomenal work that they did, and all the work group members. It was lots of intense deliberations. I also think today's conversation has been very good in terms of bringing up different of opinion, the complexities. And what I would say is, having listened to so many of these over the years, that this is complex and challenging, but it is one of those times where we need to focus on the policy question before us. Is it safe? Is it effective? Is it feasible? We didn't get to ask, is it easy? We know this is not going to be easy. So I think what will happen is practice will follow our policy, and we will come back and re-review and discuss and measure. And that the practice barriers is what we need to make sure that we're working on. But it really does come down to, in all of these things, the clinician is the linchpin. The clinician is the one who's going to be discussing the options available, and they will need to be prepared with their own educational needs, attending the COCA calls, listening into NFID webinars, and making sure that we are prepared to share this with families. And then we have to make sure that we are also fixing the other thing. Grace, I'm very much in your camp about the quality improvements, that we can't wait till we have all of the technical and financial and other reimbursements in place when we have a very good product before us. So I would say we've got to make sure that we're communicating with our peers and parents alike, and take these barriers into consideration, but not let that be a barrier to advancing a very good product. And then we will look at both of these very good products and go from there. Thanks.
Thank you, Ms. Stinchfield. Any other questions? Okay, I appreciate my members putting on their video camera. We're going to go ahead, and I'm actually just going to go in order of the video that you're on my screen. So we'll start with Dr. Paling. Oh, and sorry, you know the drill, but name, conflict of interest, vote. Thank you.
Thank you, Dr. Lee. Kathy Paling, no conflict, yes.
Thank you, Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you. Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Dr. Talbot.
Dr. Talbot, no conflicts, no.
Okay, thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Cotton.
Neil Cotton, no conflicts, yes.
Thank you. Ms. Bata.
Lynn Bata, no conflict, yes.
You. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen, for some reason you're not showing up on my screen. There you are, Dr. Chen.
Okay. Wilbur Chen, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflicts, yes.
Thank you. And Lee, no conflicts, yes. Dr. Wharton, if I counted correctly, I think it's 11 yeses and 1 no.
I counted the same way you did, Dr. Lee. So the
Okay, thank you. So this motion passes, and the maternal RSV recommendation is now approved. I wanted to, why don't we go on to the VFC vote, but I did want to make sure my colleagues had a moment to comment on either of the votes. So feel free to raise your hand after this next vote. So the VFC vote language is to approve the resolution for RSV maternal vaccine. And I will ask, I'm going to go in reverse alphabetical order today. So we're going to start with Dr. Talbot. Name whether you have conflicts of interest in your vote for the VFC vote language.
Oh, this is hard because I don't want to create a disparity, but I still disagree. So Kip Talbot, no conflicts, no.
Okay, thank you. Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Dr. Lair?
Amy Lair, no conflicts, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Bell?
Bell, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflict, yes.
Thank you. And Lee, no conflicts, yes. So Dr. Warden, I have 11 yeses and 1 no, and the VFC vote passes.
Yes, Dr. Lee, it was an 11-1 to vote.
Thank you. Okay. So now I'd like to open it up to the members. If anyone would like to make comments about their vote or any additional comments they would like to make with regard to this complex vote. Please raise your hands. Dr. Paling?
Yeah, I want to say thank you to everybody. RSV throughout my career has been a difficult disease with just supportive care treatment because there have been no options. So today is an exciting day. We know that there's over 1.5 million outpatient visits, over 500 million ED visits, and 58 to 80,000 RSV hospitalizations, which we saw dramatically last year as an example. And we also know that the vast majority, almost 80% of children less than 2 years of age have no underlying conditions. There is nothing simple about this RSV vaccine, nirsevimab, but they give us both hopes. We've done this before with COVID vaccine, and I think if everybody's willing to chip in and do their part, that this is feasible and will improve the well-being of many families throughout our nation. Thank you.
Thank you. Dr. Bell?
I just wanted to take advantage of my gray-haired status here and reflect for a moment on this issue of complicated recommendations where implementation is unclear, difficult, not that the implementation is going to be difficult. There are a lot of challenges. And I will say to your point earlier, Dr. Lee, that in looking back over decades, hepatitis B vaccination being an obvious one that comes to mind, I think these sorts of recommendations that provide an opportunity for innovation, that provide availability of different options, oftentimes, while at the beginning might be extremely bumpy, oftentimes do drive improvements over the longer term. And I think that this is another example of that. It allows perhaps for improvements in physician education, patient decision-making, communication between the obstetrical world and the pediatric world, addressing disparities. So even though we as ACIP members at this moment in time may feel like, whoa, this is really complicated and it's going to be very difficult to implement, I think in the longer term, as I say, it provides an opportunity and some new options that I think will improve children's health in the longer term.
Thank you, Dr. Bell. Dr. Sanchez?
Thank you, Dr. Bell. But I completely agree with you as always. I just want to say that the discussions today really have been extremely helpful because I certainly have struggled with my decision throughout the time that I've been on the RSV work group. I have fluctuated. First of all, I just went back and forth. And I think the discussions today, the CDC presenters, again, Jefferson and Catherine, have steered me through all the RSV work groups and Dr. Long as well. It's just been amazing. And Cody Meissner as well in the RSV work group. It's been a really, we have recognized all the challenges and all of the complexities that have been brought up today all of that has been discussed in the RSV work group. Nothing that was said today was nothing different than we anticipated, because there are complexities. And I think the complexity is that the mother and the healthcare provider, actually, we have options. I mean, if we only had the RSV vaccine to offer, it would be simple. We would just be saying, yes, they should get it. But we do have options. And we, as physicians, when we care for our patients, we do have some personal preferences that do, I think that is part of the physician-patient discussion. And so I think that these options are great. We, as a pediatrician, infectious disease specialist, neonatologist, we have to prevent serious RSV disease in our babies. And I think that we've achieved this vote, as well as with the nirsevimab. We have really achieved it's been fantastic. I mean, I could not have imagined a better options for our infants and children. I mean, this is what we've been striving for. And as a neonatologist with high-risk babies, this is just fantastic. And so I think, getting back to Dr. Bell, I really urge that this will bring more discussions with the obstetricians, the mother's healthcare provider, and the pediatric family practice, whoever's taking care of the baby, because we need to know, just like we need to know the mother's syphilis status, the HIV, the hepatitis B, we also will need to know whether the mother received the vaccine or not. And I think this will ultimately, hopefully, improve care and communication with with our obstetric providers. And so, thank you.
Thank you. Dr. Brooks?
Yes, thank you. When I think back to the quiet days and we thought that PCV discussions were complex. So yes, this has been very complex, but as we move forward, we're going to likely have more complex decisions to make. Kind of dovetailing on what Dr. Sanchez said, one of the things that struck me is that a large number of obstetricians feel uncomfortable with discussing vaccine decisions. We looked at the schedule, and there are 4 vaccines that could theoretically be available or needed for a pregnant person: RSV, COVID, influenza, and Tdap. And we're talking about October through March. That's half the year. So that's a significant amount of time where there are going to be some really interesting discussions. So we really need to maybe lean on ACOG to really get with their members and feel more comfortable with these discussions. I would say that one of the benefits to me is a fundamental concept of vaccination, which is, generally speaking, you want a person to get vaccinated at their earliest opportunity. So the earliest opportunity would be while the mother is, while the person is, before they've delivered. So that concept of immediate protection, I think, is very, very important. And the other thing to think about is what happens if situations change, if the person leaves the country, if their insurance status changes, if some changes in their perspective on protection of a child from RSV. So I think it's very important, in my eye, to get them vaccinated as soon as possible. Notwithstanding Dr. Lehr's statement that nirsevimab seems to be a more effective and cost-effective, or efficacious and cost-effective. So I think that it is excellent to have this option for the vaccine for the pregnant person prior to the birth of the child. Over.
Thank you, Dr. Brooks. Ms. McNally.
Thank you. I struggled with this recommendation today for the reason that I don't know what the counseling looks like for the mother who asks her OB if she should get this vaccine, and the mother who would ask the child's pediatrician what she should do. So because of that, I agree with Dr. Lee that I think if the stakeholder medical associations could get together and prepare a statement about this issue, I think that would be immensely helpful for the consumer. And I also want to note that it would seem like we have discussed shared clinical decision-making recommendations a lot more lately. And that gives me a certain level of discomfort as a consumer because while I believe there is a place for shared clinical decision-making, it makes me nervous that there would be some baseline assumptions about the knowledge that consumers have for risk of disease. And I wonder if there is a way to talk about best practices to revisit this idea of shared clinical decision-making in order to help us arrive to better decisions in the future regarding vaccine recommendations. Thank you.
Thank you, Ms. McNally. Dr. Talbot.
I really want to reiterate how important it is that the medical societies work on this process. The pneumococcal vaccines have been complicated for years and had to be written out of the ID boards because they were too complicated. And I worry that you have created another very complicated recommendation. And what happened with pneumococcus is we had low immunization rates. So please, please, every society needs to talk. There needs to be massive education, and you need to do it better than what we did for pneumococcus.
Thank you. Dr. Cotton.
So I appreciate how complicated the decision-making was through all of this. I am excited to see that we are at a time where we have shared clinical decision-making for adults 60 years of age and over. And then we have pregnant people, RSV vaccine, and monoclonal antibodies for infants, in that this is a horrible disease for many, especially immunocompromised. And I am cautiously optimistic that we will see diminished rates of disease in multiple communities that hopefully may result in decreased transmission to vulnerable populations. And I think this is an exciting time in the medical world. And I'm excited to see what things will look like with multiple protective vaccines for many, many different populations. Thank you.
Thank you. I don't see any additional hands raised. Oh, Dr. Long, please go ahead. Perfect way to close.
Yeah, I just wanted to say I'm not cautiously, but I'm outrageously grateful for all of you to think through this again today with us. We have had, I couldn't even add up all the hours that we've struggled with these things, and appreciate all of everything that you have said. I do think this is the right decision today, and we shall see through a very messy year, but maybe it will be clarified over time if one rises to a preference over the other, and hopefully that both will become less expensive. Thank you all very much for the input.
Thank you, Dr. Long. And with that, I will ask my members if you would like to turn your cameras off, please go ahead, and we are going to move on to the next part of our session. So our next session is Adult and Pediatric Immunization Schedule Addendum, and I see Dr. Sarah Schill will be leading us through this discussion. Dr. Schill.
Good afternoon. I'm happy to be here to talk about an addition of an addenda to the immunization schedules. So as a recap, the immunization schedules are published on an annual basis, typically every February. There are two separate schedules. There's the child and adolescent schedule, shown here in purple, that covers persons aged birth through 18 years. And then there's the adult schedule, shown here in blue, that covers persons age 19 years and older. There are multiple sections in each of these schedules that summarize the approved ACIP policy, including the cover page, which is what's depicted here, the tables section, which contain graphic rows of recommendations, the notes section, and the appendix. The schedules are published in three formats: as a PDF version, as a web page, and as an app. The 9 professional organizations listed here partner with CDC to approve the schedules, And some of these professional organizations publish the schedules. This slide shows the cover page of the adult schedule. You'll notice in the upper left-hand corner, there's a box with 4 steps on how to use the schedule. This slide shows one of the tables in the adult schedule. There are similar tables in the child and adolescent schedule. And this slide shows pages from the notes section of the adult schedule. And then the appendix includes contraindications and precautions. Traditionally, the schedules are published in February, but the publication process starts in October with the ACIP vote. In November and December, professional organizations approve the schedule, and in December and January, we draft and enter into CDC clearance, MMWR reports, and an internal Annals of Internal Medicine report. And then in February, the schedules are published along with the accompanying MMWR notice to readers and Annals of Internal Medicine report. The timeliness of schedule publication has several important implications. First, some insurers link vaccine reimbursement to the vaccine being listed on the immunization schedule. Second, the ability of certain healthcare providers to administer immunizations is also related to the schedule. For example, some states link pharmacist immunization authority to the schedule. And lastly, healthcare provider knowledge and practices are related to the immunization schedule. For example, if a healthcare provider is referring to a schedule that's several months old, they may not be aware of the most recent ACIP recommendations. The Affordable Care Act addresses immunization coverage and it's interpreted by CMS. According to the Affordable Care Act, insurers must provide coverage for and must not impose cost-sharing restrictions for immunizations that have a routine recommendation and that are listed on the immunization schedule of the Centers for Disease Control and Prevention. Of note, the Affordable Care Act does not specify the layout of the immunization schedule. So legally, CDC has discretion regarding the design of the immunization schedules, and it's the entire document that constitutes the schedule, not just the graphic bars or the tables of the schedule. We are looking at a 3-pronged approach to address schedule timeliness. Our immediate strategy consists of the addition of addenda to help bring the schedule up to date. Our short-term strategy involves publication of the entirety of the schedule shortly after the October ACIP vote. And our longer-term strategy is to consider sustainable approaches to ensure the schedule remains dynamic and responsive. And we will engage our partners in the planning process. So regarding the addition of the addenda to the 2023 immunization schedules, the addenda will contain ACIP recommendations that occurred after the 2023 schedule was published. We plan to release the 2023 immunization schedules with the addenda next week. And with this addition, all ACIP recommendations will formally be part of the CDC immunization schedules. The next few slides show the changes related to adding the addenda to the schedules. As you can see on the cover page, there will be a red bar added at the top to refer users to the addendum. A 5th step, also referring users to the addendum, will be added, as long as any new vaccines or recommendations for new vaccines on this table. Here is the addendum for the adult schedule. It consists of 1 page and includes vaccines for which recent recommendations have been made, a synopsis of those recommendations, and the effective date of the recommendation. The addendum for the pediatric schedule is similar. It's also one page, and it's depicted here. So in summary, we anticipate release of the 2023 immunization schedules with the addenda next week, and this will formally incorporate all ACIP recommendations into the 2023 CDC immunization schedule. We're also planning for short and long-term sustainable strategies to address schedule timeliness, and we will ensure partner engagement with this process. I'd like to acknowledge my colleagues here, and now take this time to answer any questions or hear any comments.
Thank you very much, Dr. Shilley. We actually do have several liaison organizations who wish to make comment as it relates to this particular topic, many of whom are engaged in the schedule itself. So I would like to call on, actually, thank you for raising your hand. Before we go there, actually, I'll ask the liaison members who wish to make comments to please raise your hands, but I will ask, Dr. Paling, we'll come back to you. Thank you. Dr. Goldman from American College of Physicians.
Thank you so much. So the American College of Physicians, with over 160,000 members and the largest single specialty medicine organization representing all internal medicine specialists, greatly appreciates the work of the CDC and the Advisory Committee on Immunization Practices, and especially the willingness to work with the vaccine schedule. The college understands the challenges of analyzing copious amounts of data to put forth the best evidence-based recommendations. There is, however, as noted, a need for timely updates to the vaccine schedule so that practicing physicians can have guidance in implementing those guidelines. Obviously, one of those challenges we face is the delay created between approval by the committee, sign off by the CDC director, and final publication of the schedule as was presented. And we know the Affordable Care Act allows insurance companies to have up to a year to cover these life-saving vaccines, but many will start that year at final publication and not approval by the committee. It is imperative that the schedule be updated, approved, and published as quickly as possible to avoid unnecessary delays in implementation. The college greatly appreciates the willingness of the CDC to expedite this process. The lack of insurance coverage creates unnecessary barriers to access to care and further exacerbates healthcare disparities, as uninsured and underinsured patients will not have access to these vaccines. We also strongly agree with the need for a Vaccine for Adults program to address those gaps in coverage so patients can get the vaccines they need. Finally, the American College of Physicians would ask the vaccine manufacturers to provide vaccines fairly and equitably without preferential distribution to large systems and non-physician entities so that the physicians can vaccinate patients in their office in a timely manner. Specifically, the delays in distribution of flu vaccines this season to many physician offices has created hardships for patients and decreased access to care. Once again, the ACIP is supportive of the good work of the committee and look forward to our continued collaboration to advance health equity and access to life-saving vaccines. Thank you.
Thank you. Dr. O'Leary?
Yes, thank you. I have a statement on behalf of the AAP. The immunization delivery system is complex with many interrelated parts that need to work together to ensure that our nation's children can receive timely and equitable access to vaccines. This is particularly true when new vaccines are recommended by the Advisory Committee on Immunization Practices. Once the ACIP makes a recommendation for a new vaccine and the CDC director signs off on the recommendation, this prompts a series of steps that are critical to ensuring smooth and equitable rollout. The publication of official CDC recommendations is an essential step in this process. As an example, consider the PCV20 vaccine, the pneumococcal conjugate vaccine, which was recommended by the ACIP at its June meeting. AAP members have recently reported that some VFC programs are providing only PCV20 and that some vaccine buying groups are directing people to use this vaccine over other pneumococcal vaccines. However, this is problematic because a lack of formal recommendations in an updated immunization schedule or publication in MMWR is leading to payment denials for PCV20, as well as delays in TRICARE coverage for children in military families. Timely updates to the immunization schedule would provide pediatricians with an authoritative source for the latest immunization recommendations, which is invaluable at the point of care to maximize every opportunity to vaccinate. The American Academy of Pediatrics strongly supports the efforts of the CDC to update the immunization schedule on an as-needed and timely basis. Thank you.
Thank you. Ms. Good?
Thanks, Dr. Lee. So on behalf of the nation's 330,000 pharmacists, the American Pharmacists Association, APHA, is pleased to provide supportive comments on the importance of timely updates to the vaccine schedules. APHA, representing the profession of pharmacy, is honored to be one of the organizations granted the opportunity to review and indicate support of the adult vaccine schedule. Over the past 20 plus years, pharmacists and their teams have protected the public from vaccine preventable diseases by recommending and administering vaccines, most notably of late, administering well over half the COVID-19 vaccines during the pandemic. APHA recommends updating the schedules as recommendations and clinical guidance are approved by ACIP. It is important for policy and patient access to vaccines. An example is the RSV vaccine. ACIP voted on the recommendations in June for the vaccine to be administered as soon as vaccine becomes available and throughout the RSV season. However, currently, it will not be on the vaccine schedule until February. States regulate vaccine administration by pharmacists and pharmacy personnel. Several states require that vaccines must be on the CDC ACIP recommended schedule for pharmacists or pharmacy personnel administration. The gap is that many thousands of patients will not have access to the RSV vaccine until February if the schedule updates are not accelerated. Given the number of patients who receive their vaccines from a pharmacy team member, especially those in rural and medically underserved areas, it is imperative that the vaccine schedules be updated as new vaccines become available and recommended by CDC ACIP. Therefore, APHA strongly supports timely updates to the vaccine schedule for newly recommended vaccines to facilitate access to vaccination by pharmacists and pharmacy team members, and that payers be strongly informed that they do not need to wait for publishing of the MMWR or the updated schedule to begin coverage of ACIP recommended vaccines. Thank you for the opportunity to comment today.
Thank you. Dr. Rockwell.
Hi, thank you. My name is Pamela Rockwell, and I'm representing the American Academy of Family Physicians, and we thank you for allowing us to provide comment today. Family physicians provide care for people of all ages from birth through end of life, including care for those pregnant. AAFP feels strongly that timely updates to the vaccination schedules is extremely important to allow family physicians and other healthcare professionals to determine who is due for vaccination and quickly. Many of the newly updated recommendations are scattered throughout CDC web pages and not easily accessed. And as we enter the fall respiratory season, many family physicians have expressed disappointment that updates on several vaccines, including influenza, pneumococcal, RSV, and COVID-19, are not easily accessible on the harmonized child, adolescent, and adult vaccination 2023 schedules. However, I'm encouraged to hear from Dr. Schilly about the addendum to be added to the immunization schedules next week. But to summarize, AAFP encourages continuous and additional timely updates to the schedules as new vaccine recommendations are added or amended, and as these are essential to ensure continued prevention of disease and improve public health through vaccination. Thank you.
Thank you. Dr. Hopkins?
Thank you, Dr. Lee, for the opportunity to comment on behalf of the National Foundation for Infectious Diseases. I'm Dr. Bob Hopkins, NFID Medical Director and ACIP Liaison. On behalf of NFID, I want to thank ACIP for its ongoing work to ensure the availability of safe and effective vaccines and monoclonal antibodies to help protect the most vulnerable individuals from RSV. I further want to thank ACIP for the addition to the ACIP schedule and plans to continue to update these schedules in the future to avoid some of the challenges with reimbursement and coverage. RSV impacts individuals of all ages, including premature infants and infants younger than 6 months. Each year in the U.S., RSV is estimated to cause more than 2 million outpatient visits, 58,000 to 80,000 hospitalizations, and 100 to 300 deaths among children under 5 years of age. While immunizing pregnant women will be a tremendous step toward RSV prevention, healthcare professionals will continue to need clear guidance and education to inform their decisions with patients and parents about the use of vaccines in pregnant women and/or nirsevimab in infants. NFID is committed to collaborating with CDC and partners in educating healthcare professionals and the public to help facilitate the effective use of these active and passive tools in RSV prevention. The low uptake among pregnant women of vaccines to prevent flu and COVID-19 underscores the importance of building confidence in all recommended vaccines. As partners in protecting public health, we must focus on using all available tools to prevent RSV and protect those most at risk. For 50 years, NFID has been dedicated to educating and engaging the public, communities, and healthcare professionals about infectious diseases across the lifespan. NFID commends the tireless efforts of ACIP in guiding U.S. immunization policy, and we stand ready to support the work of ACIP and CDC, which is instrumental in saving lives and protecting public health. Thank you for the opportunity to comment.
Thank you. Ms. Stinchfield.
Yes, thank you so much, Patsy Stinchfield. On behalf of NAPNAP, the National Association of Pediatric Nurse Practitioners, I'll just add my voice to so many of the other association colleagues to say how important the updated schedule is. It's our tool, it's an outline, it's not all the details, but it is critical for us to practice, and also the great work that we've had with our RSV vaccines and products will make that schedule even more important. And I would say on behalf of pediatrics, we all know that RSV in that end of the age group, as well as the older age group, this can be a devastating disease. So today is a very, very great day in the prevention of disease in both the young and the old. Thank you.
Thank you. And I would like to next recognize Kayla McFeely, who is representing the National Association of Chain Drugstores.
Thank you so much, Dr. Lee. I'm a pharmacist representing NACDS. We strongly support an updated schedule in an expedited fashion. As was presented, this issue is causing real-world vaccine access barriers and delayed vaccine uptake. Today, this is resulting in unnecessary scope of practice barriers in certain states that hinder pharmacists' ability to administer RSV vaccines for older adults, and it's impacting health insurers' willingness to cover these vaccines. So we encourage CDC and ACIP to help avoid this challenge in the future by updating the immunization schedules effective immediately upon new recommendations in order to mitigate unnecessary access barriers and delays in vaccine uptake. We are very much looking forward to the addenda next week. So thanks so much for your work, and thank you for considering this very important issue.
Thank you. Dr. Zimmerman.
Thank you. Richard Zimmerman, the Association of Prevention, Teaching, and Research Liaison. I will join the chorus in supporting ongoing efforts to update the immunization schedule in a more real-time fashion for two basic reasons. One is to make it easier for practitioners and clinicians to keep up to date with the rapid pace of changes in vaccine science. And secondly, for what's been mentioned by so many others, the financial barriers. And this is particularly important as I work in a fairly qualified health center where I see firsthand the issues of disparities, of equity, and of financial barriers to preventive services, including vaccinations. So we appreciate this update. Thank you.
Thank you. And I just want to thank all of our liaison members for engaging so deeply and passionately about the issue. I want to thank the CDC and Dr. Schilly for leading these discussions. I think you hear a strong consensus for a dynamic immunization schedule and for it not to be a barrier to implementation. So this presentation is now open for additional questions. Dr. Lair.
I'd like to second Dr. Lee's thank you to Dr. Schilly and to the CDC. Thank you for being responsive to your constituencies and making it easier for us to get vaccines into the arms of our patients. I have a fairly specific question, which you may or may not be able to answer. It's about the CDC Vaccine Schedule app. It's something which I use on a regular basis. I've used a number of other apps, but the one the CDC puts out is my favorite. Do you know if these addendum will be posted on the app when they're posted on the internet? And do you know if there's what's called a push feature, that when the website changes, that the app changes? I'm just curious about that. Thank you.
Thank you. I'm going to see if either Dr. Murthy or Dr. Wody, who I think are on the line, could answer that question, please.
Yes, this is Dr. Wody on the line. Yes, we plan to add the addendum to all versions of the 2023 schedule. So that includes the web pages, PDF, and the app.
Thank you.
Dr. Paling?
Yes, I want to say a very special thank you to Dr. Shilley, your entire committee, all contributing organizations, and the entire CDC to create a mechanism to update immunization schedule. We do recognize that this edition does take a lot of work. We want to thank you because this change in keeping this updated will importantly increase access, address financial barriers, improve the health and well-being of so many persons across the United States, and enhance equity. This is the best news. Thank you.
Thank you. Are there any additional questions or comments? I do have one consideration for our colleagues at CDC. So first of all, I will say I very much appreciate the ability to dynamically update, because I think that will make a difference both to folks who are trying to just give these vaccines, to be able to look in a single place for it, but also to facilitate in removing any barriers that, while we understand why it's necessary for financing and for implementation reasons to tie it to the schedule, to not have it be sort of a once a year decision point, given that we have made so many decisions, at this point every week, sometimes every month, that changes over time. So having the ability to adapt, I think, is huge and puts us in a new place. One sort of longer term thought for the group will be, as we continue to expand our thinking and our recommendations for certain populations, will be to think about how to also expand our thinking around the schedule, for example, for those who are pregnant and their neonates, sort of being able to call that out in the immunization schedule may help to also facilitate those conversations we discussed in the last session. I'll also just highlight for my colleague, Dr. Cotton, that those who are immunocompromised, having consistency and standardization around at least how it's being defined, recognizing that each vaccine covers different populations, is another opportunity. So we'll continue to ask our CDC colleagues if they're willing to innovate with us as we continue to grow out these complex recommendations as a way to make implementation easier for the front line. So thank you. And I'll turn it over to Ms. Bata.
Thank you. A consideration that I would ask of our CDC partners, and I am really excited to see this develop so that we can have these timely recommendations. My consideration would be to make available the clinical guidance that goes with these recommendations. That's an important part of how we help our clinicians actually implement these vaccinations. And it oftentimes is a core piece of standing orders or protocols for immunization. So that's my request.
Thank you. And, I think we, agree that, all of these materials that aid in implementation, the timeliness has many downstream effects. So I think we're on the same page, certainly.
Any additional questions or comments? Dr. Wharton, is there any other business that we have that needs to get discussed?
Dr. Lee, no, there's no other business, and I believe the committee could adjourn.
Okay, well, with that, thank you, Dr. Shilley, for your presentation. And actually, you can hear the appreciation from the webcast. I want to just take a moment to thank our CDC colleagues for their outstanding work. It's been a really tough few years, and I have to say a tough month for our CDC colleagues. You can tell the same people are presenting week after week and preparing for these meetings. So I just want to recognize them for the incredible work that they do on behalf of the committee and on behalf of the public to be able to make sure that there is a robust deliberation on all of these decisions that are in front of us. I also just want to take a moment to appreciate the CDC for ensuring that these challenging decisions are discussed openly and transparently through the convening of our advisory committee. As challenging as it is for us to meet so frequently, I have to say that both as a member and soon to be a member of the public, I think this is an incredibly important process that continues to be upheld by the CDC, even through the pandemic, when I think there have been multiple challenges with continuing this. But those of us who are providing the vaccines, who are counseling patients and our healthcare workforce on vaccines, really, and immunizations, really appreciate being able to hear these discussions in order to be able to better reflect the nuances and the complexities and the deep understanding and thought that goes into these decisions, that these are not simple decisions that we make on behalf of the US population, but really ones that have a lot of thought and care put into it by our CDC team, by our work group members, by our ACIP members, by the liaisons and our ex officio partners. It's really incredible to be able to bring this to the public in such a thoughtful and meaningful way. So I want to thank all of our speakers, ACIP ex officio liaison members, and our CDC colleagues for your work today and over the past few years. And since we do not have any additional business, and I'm going to ask if there's any objections to adjourning today's meeting. I don't see any hands raised, so I will now declare today's ACIP meeting adjourned. And thank you everyone for your service. We look forward to the updated committee convening in August. Thank you, everyone.
October
sounds better. Thank you. Take care.